Welcome, everyone. Thank you so much for joining us today. For those who don't recognize my voice, my name is Jillian McConnell, and I'm the Knowledge Translation Specialist with brainXchange. And on behalf of my colleagues from the Canadian Coalition of Seniors Mental Health, also known as CCSMH, we welcome you, and we're so pleased that you're able to take part in this webinar event. A few housekeeping items to address before we get underway with today's presentation. The audio is provided solely via your computer speakers, so please ensure the speaker icon on the top of your screen is green, and that your speaker volume is set high enough for you to listen. On the top corner of your screen, you'll find the Q&A box. If you have a question about the webinar, please type into the Type Here box at the bottom of that Q&A section and hit Enter. That's how you can communicate with me and my colleague during the event. I do want to note that only the presenters and I can see your questions, not your fellow participants. And that box will appear throughout the webinar, and it's also where you can send your questions during the Q&A portion of our event, which will take place in the last 15 minutes of the hour. A copy of the slides from today's presentation will be made available through a link posted at the end of the event, and the link will also be located within the event listing in the brainXchange website. The presentation itself is being recorded, and within 2 to 3 business days, it will be up on the brainXchange site under our archived events section. All participants will receive an email in their inbox notifying you when that recording is ready, and we encourage you to pass on the link to any of your colleagues who weren't able to join us today. If you are having technical issues, we ask that you respond back to the confirmation or the reminder emails that you received, or alternatively, you can send an email to webinars@brainexchange.ca. You can see that email address hyperlinked in blue in the Q&A box, and we will be able to assist you via those 2 methods. So for all intents and purposes, those are the major features you really need to be familiar with for today. So now that brings us to introducing our topic and our presenters. So the title of today's session is Bringing Hope into Your Clinical Practice, and features our presenters, Dr. Ronna, Jevne, and Peter Snow. Dr. Jevne is passionate about healthier emotional lives for all, from children to seniors, from volunteer to professional, from the mainstream to the disenfranchised. Her career has spanned decades as a teacher, psychologist, professor, inspirational speaker, and author. She is a founding member of both the Canadian Association of Psychosocial Oncology and Hope Study Central, a research center at the University of Alberta devoted to the study of hope. Author of more than a dozen books, she is known for writing for those she serves. She has received such awards as the Pettifor Award for Outstanding Contribution to Psychology, the YWCA Women of Excellence in Social Sciences, and the University of Alberta Board of Governors Award of Distinction. Peter Snow is a knowledge broker with the Canadian Coalition for Seniors Mental Health. Prior to working at CCSMH, he spent 10 years in frontline mental health care. So on behalf of everyone on the line, I welcome the both of you. And Peter, I believe you're getting us started, so I'll turn the floor over to you.
Thank you, Jillian, and thank you, brainXchange, for hosting this with us today. Just very briefly, talk about any conflicts of interest we might have. Just mention that the work that I do with CCSMH has been funded by the Public Health Agency of Canada, and Dr. Jevne has none to report. So just want to give you an overview of how this is going to work. So today we're going to be discussing 5 questions about hope as it relates to clinical practice. So the idea is that Ronna and I are going to have a pretty free-flowing conversation. If you have questions, as Jillian mentioned, you can put them in the Q&A and we'll address them towards the end of the presentation. All right, so I think without any extra circumstance, we're going to get started. So our first question we're going to talk about is what makes hope different from things like resilience or optimism or wishing. So Ronna, I'll let you take the first crack at that question.
What makes hope different?
Yeah.
I want to go back just for a sec to say there's no universal consensus about the definition of hope. And so one of the things we needed to do at the research center was make sure that we could differentiate hope from some of the other related concepts, and so that we weren't reinventing the wheel. So there is a difference in resilience. There's a difference in coping. There's a difference with regard to faith. Probably two of the most important is to notice that coping is about doing. Hoping is about anticipating, or it's more of a existential experience. There are authors that talk about goal and authors that talk more about what we might call soul. But one of the most discerning factors is that hope has a goodness factor. And we did a very large study and a somatic and differential that suggested that you could be resilient, but not for a good reason. And sometimes you could be coping, but you were literally dying on the inside. You were managing life, but you were just really struggling with your inner life. For myself, I like to go with a colloquial or a very simple definition of hope as the yes to life. Not yes if it's good, yes if it turns out, etc. But yes, I'm willing to envision a future in which I'm willing to participate. I also have a professional definition that involves the idea of hope as an orientation, a way of viewing the world, a lens for the world. And that particular orientation is almost a search behavior for anything that could contribute to my physical or emotional survival in a positive way. Stop me whenever I've said enough.
Well, yeah, no, just to jump in on that, I think, the thing with hope, and I think it's where maybe a lot of people get stuck, is we sometimes think of hope as having to be like a belief in that everything in life will be okay, right? This idea, like, I think when people, like, in conversation, when you talk to someone about hope, that might be what they think, that like, oh, hope just means, I know things are going to be fine, which is, from research, and we all include, but that's not true, right? Hope can exist even in situations that aren't going to turn out okay.
Well, and that's part of what the center was studying was, like, there are certain situations that the outcome is not going to be, Pollyanna. I always remember a cancer patient saying, I finally figured out hope is not about everything turning out okay. It's about being okay no matter how things are going to turn out. So it's the, whether you want to think of it as behavioral or cognitive or emotional or existential, it's what makes it possible for us to coexist with uncertainty.
Yeah. Yeah, and as you say, it's all those domains, right? Like, it crosses multiple aspects of being a person, right? It can be psychological, it can be emotional, it can be a lot of things. So this idea that when we try to find hope, and we'll come back to this probably later when we're talking more about strategies, but when we're trying to find hope for the people we're working with, and also for ourselves, right? A lot of us working in this field, a lot of days don't feel very hopeful about, situations for people we're working with or the state of the world. We can feel, that there's no reason to be hopeful or to feel any kind of hope. But again, hope not meaning that, everything's going to be fine, but that, as you mentioned about that idea of like saying yes to life, or, wanting to live, or, feeling that there's, something meaningful there or important there, even in the face of what could be very dire circumstances. Absolutely.
Well, and even if your own hope is really key to this. For example, when we were doing workshops for physicians, we would give them a scenario. And then we would ask them to rate the hopefulness in this scenario. Well, they were really fascinated when, on a scale from 1 to 10, and we usually had them stand up and say, okay, 1's over here and 10's over here, and put yourself somewhere along the continuum of that hopefulness. And there'd be people, physicians, healthcare providers, who would be at 1. And somebody else, I always remember one fellow who said, well, I'm an 11. And then they would start the discussion, how can we be viewing this particular scenario or case and have such divergent views about how hopeful it is? So indeed, it's a curious way of looking, what I call being oriented to life.
Yeah. Well, it really changes how we approach situations, right? What you just described. You know, I can think of examples in my own practice where you'd have a person you're working with and saw some people in some very bad situations and circumstances in their lives. And, you know, some people would view that and go, well, you know, what's the point? What are we doing here? Why are we trying to help this person when X, Y, Z? You know, and it sort of shuts that clinician down, right? They won't try stuff. They won't do things. They won't get involved. And then on the other side, if someone's like, no, like there's opportunity here. There's, you know, reasons to keep trying. You know, there's things can happen, can be different, or whatever that perspective is, that 11 out of 10 for hopefulness, you know, then you try stuff, right? You keep doing things. You keep working towards, you know, goals. And a lot of times, you know, that makes a difference in terms of what the outcome is going to look like for that person, you know.
Well, and one of the things to remember is that hope is not about probability. Hope is about possibility. And so when you think about, you know, whether or not, you know, the outcome's going to be good, we often think about large group studies, not about individuals, and we always think about the future. So we're thinking about the percentage of people who make it. I mean, one of the people who helped start Hope Studies Central was sent over by the head of the cancer hospital that I worked at, and he said, this guy just refuses to hear what's going to happen. Well, 11 years later, he died of something else. Now, that's a remarkable thing. But when he came, he said, they tell me that I have a 4 to 5% chance of being alive in a year. And he said, I want to know who's in that 4 to 5%. Now, that is really a strong framework, but hope is always about a possibility. It is not dependent on a probability.
Absolutely. I think we'll move on to our next question, just being mindful of our time today. All right. So, and I think we've touched on this a little bit already, because this idea of, you know, what you know, we kind of talk what hope is, but also the role of it, right? Where does hope fit in? You know, and for obviously for our audience, we're talking about clinically, but also in terms of life, you know, the difference that hope can make. And we've started touching on that right now in what we've been talking about, in the way that, like, you know, someone who feels like, you know, there are those possibilities, even if they don't seem likely, will continue to try things, will be, you know, more willing to, you know, push forward in their lives and have a higher quality of life in some ways, right? Like, I mean, that's, I think, a big part of it is that the hopefulness improves the time we have right now, because we can start to work towards, you know, those other possibilities, or just to accepting our situation for what it is.
Yep. And I know that we're talking to a healthcare community, and that's my interest as well. But this has gone well beyond that now. I mean, it was 1959, Carl Menninger pleaded as the president, and in his presidential address to the American Psychiatric Association, he said, pay attention to this thing called hope. And yet it was 1988 before hope got into the psychological or medical abstracts. But it's gone beyond that now. There were, honestly, you could get everybody researching hope in a phone booth in the mid-80s. And now it's a prolific field. And we know it makes a difference to students and their achievement. We know it makes a difference to palliative care. Patients. We know it makes a difference to the caregiver, absolutely. And the lay caregiver, like a spouse or a child or a grandparent, we know, and every one of you listening knows, that you know which of your colleagues are hopeful and which are, you know, approaching hopelessness. And by the way, hopelessness is a far higher predictor of suicide than depression. If you want to know a lot more about the evidence, Hope Studies Central has the largest bibliography in the world related to hope. It's free, and on the website of Hope Studies Central, just do the drop down on Hope Literature Database, and there are hundreds and hundreds of studies, well organized, so you can find the kind of study that you're looking for. But the value of hope is no longer in question.
Yeah, and I like that you mentioned that fact about suicide. I know from my work in working with people who are suicidal that hopelessness and hopefulness are actually the central thing, right? That whether there's that feeling that there is a purpose, there is a reason. There's someone who works in this field, his name actually is escaping me right now, who talks about the difference between living to die and dying to live. And I really think hope is part of that, because hope is, it's such a big part of that, because, the idea that, if I want to live, there has to be some reason. And those of you who are doing any kind of suicide treatment right now know that finding reasons to live and amplifying those reasons are really important. And yeah, hope is obviously central to that. Yeah.
And meaning and relationships are very strong factors in the experience of hope. Not the only factors. Another factor that comes into that, which might seem a little strange, is that hope is triggered often by a sensory experience. And so sight and images and sound and those things. So yes, it's intangible, but it can be identified. And it's often identified if you'll take the time just to hear even part of the patient's story. And I know that's time consuming, but it's also often time efficient. When we first started this work, we sent out interviewers to interview people about what is hope for you. And they came back and they said, Ronna, no matter what we ask them, they tell us a story. And you will find the triggers for hope in their stories, as you will find it in our own stories.
Absolutely. Absolutely. And I think too, like you mentioned about, getting it from people, and even asking, like the idea that you would ask people directly about it, right? Just bringing that into the conversation.
Right, and we'll talk a little in a few minutes about the fact that there's sort of 3 different levels. Sometimes you talk to them directly, sometimes it's just your framework, and other times it's just much more informal.
Yeah, absolutely. Right. Well, on that, let's move. So this question fits, much more for you, Ronna, than me, since you've been the researcher for decades. So how do we measure hope? How do we actually, like anecdotally, certainly we can do it, talking to something, how hopeful do you feel? And you mentioned rating scales, but how really do we measure it?
Well, I would suggest that we think of 2 things. One is, how do we assess it? And the other is, how do we measure it? For the most part, measurement can stay in the realm of research. But we do have multiple scales now for children, for palliative care, for caregivers, and again, basically all you have to do is Google measures of hope and you'll see how many there are. There are some that measure more of the, what do you want to happen, the future orientation, but there are many that measure more of the, how do you feel, what is the experience of hope. So I think sometimes we try to make important what we can measure rather than try to find out how we can measure what's important. But also, it's interesting sometimes because not only are we assessing a patient or a client's hope, but remember, they're assessing yours, and they're good at it. So if they feel like they're with someone who doesn't give them much hope, that can influence them in a very negative way, or it can also make them go, I need to see somebody else. But I don't know how to describe it, but in conferences I used to say, it's very difficult to say how to assess this, or even the most common question in a conference is, what is your definition of hope? And I would say, when you're talking to patients, when you're talking to veterans, when you're talking to disabled, they never ask that question. They know what it feels like. And so it'll be in their eyes, it'll be in their questions, it'll be in their, so I think assessing hope is a bit different than measuring at hope. And the
I
fellow
think
that
that's
helped
really
start the center, he was just determined. And he had it. He had large doses of it, and you could tell that. Yeah, I
Oh,
don't know if
absolutely.
that's an adequate answer, Peter, but there's
No,
a
I
difference.
think that's really, no, I like that. The thing you pointed to, which I think is really meaningful for, and you know, as we've already said once, you know, we realize that, you know, people's time is limited when they're working with people, but, you know, that idea of that holistic understanding of the person you're talking to, so like trying to, it's not just about them saying, yeah, I feel hopeful, but really, you know, or I'm, you know, 5 on a 5-point scale or whatever, but it's really looking at the whole picture of their situation, of the way they're talking, the things they're saying, what they're talking about, you know, how they're orienting themselves to their lives. Like, there's so many clues mixed in there to tell us where is this person at. Yeah.
Yeah, are they telling despair stories, or are they telling hope stories? Or if you ask them about their history, what comes up?
Mm-hmm.
So, I mean, even if it comes out, in our view, pretty hopeless, it is important to remember this can be learned. It's amazing.
Absolutely. And we can influence that too, right? Because we can influence the way the conversation goes. You know, we're going to talk more about that in a few minutes, but you know, there is that, when you mentioned, you know, you can tell the difference when a clinician is hopeful or not, you know, and so can, and definitely the person you're talking to can tell. I mean, we probably all, I imagine everyone, or most of the people in this webinar have had that experience of talking to a health professional who was not really instilling any kind of hope in them or giving them much. I tell the story when I went in for, I injured my knee earlier this year, and I went to meet the surgeon, and, you know, he was someone who, he's a hopeful guy. I could tell immediately, because he's like, yep, you're going to have the surgery and you're going to do your rehab and things are going to work out, and this time next year you'll be back up and running and it'll be great. And it's like, this guy's really hopeful for this outcome. Like, he clearly, he's like very confident that this is going to go well. And it would have been different. I've gone and said, well, you know, here's, you know, some people it works, some people doesn't, whatever. And, you know, that just that different, like, it inspired me. Like, I probably did more physio and worked harder at it than I would have had he not been so positive and hopeful about my outcome. So
yeah, and it is contagious.
Mm-hmm.
And that's why it's so important for us to pay attention to our own hope. Hope Studies Central at the University of Alberta offers a 3-week course every summer on hope. And part of it is looking at your own assumptions, looking at your own story, so that you don't use that as a template and put it over someone. If you had a bad experience, don't put it on your patient. I mean, if you really know your own hope story, and you know what assumptions you hold about hope, and you know how that relates to how you assess and treat people, then you're more likely to be constructive and not just go, well, I've seen 45 of these people and none of them have ever done well. No, it was in 1978 that I had a major and scary surgery where they said, you know, we hope we've given you a year. Well, that happens to be 45 years ago. So I just smile. So I think it's very important as well as a professional to have your own vision of what you're doing. And it's bigger than what you accomplish every day. And if you have that vision, you don't get blown away by something going wrong one day. Or, you know, optimism really is sometimes not as helpful as hopefulness, because optimism depends on outcomes.
Absolutely. You know, I worked with someone once who was considered one of the highest risk people in the city I was working with for she had multiple problems, suicide attempts, all kinds of things happening, lots of dangerous activities. Everyone seemed to have assumed that, you know, she was on borrowed time. She was very young, but she was on borrowed time. And I worked with her, and, you know, we did lots of stuff, and it was great. And I mean, I didn't do anything particularly spectacular with her to help her, but I was optimistic. I didn't, you know, it was like, yeah, let's just keep doing stuff. Like, we'll keep pushing. And she was very optimistic and kept trying. And you know what? She's still alive. And it's been 6 years. And if you would ask probably half or 3/4 of the people that worked with her professionally during that time, they would have given her a year. But she's still going. And that's fantastic. And you know, her life has improved. And time has passed, and, not everyone has a happy ending, but, if everyone had just given up and said it's hopeless, go figure yourself out, I mean, there would have been no chance. There would have been zero chance.
Well,
so,
yeah, and one of the things, I know this is, it's the Canadian Coalition for Seniors' Mental Health that's sponsoring this today, and I think it's important to remember that with a senior, a future-oriented hope is okay if there might be a future, but the future's shorter, and not to take the time frame of hope so seriously. It's not always, the future can be collapsed into the next hour, into a pain-free time, into like the younger, we can focus on longer range futures. With seniors and older people, we have to say, what would I need to know about you today in order for me to understand what would be hopeful today? So more concentration on a shorter time frame.
For sure. I think that's going to, move us into our next set of questions. But also really on that point too, I think most people don't think long-term most of the time, right? Like day to day, most of us aren't sitting around thinking like, okay, what's 4 years from now? What's 5 years from now? What's 6 years from now? Like we tend to think in much shorter time frames anyway. So a more, if we're thinking about time as one of these aspects, a more closer time frame actually makes sense probably for most people, just because, 5, 6 years from now is great, but that's a very abstract concept, at least for me. Like 5 years from now, it seems like forever. I'm more worried about next week.
When I was leaving physio yesterday, there was a woman who was obviously in pain, and I said, how are things going? And she said, well, the biggest challenge is I've never been injured, I've never been sick, and I'm having to learn some patience because this is going to take time.
Mm-hmm.
And so when we left, we only had a 4-minute exchange. She said, thanks for stopping and talking. And you could just see that her hope had risen when somebody reinforced that, it's going to take time. You can't depend on today. But you also have to find today what can sustain your hope.
Absolutely. So let's start talking about that. Let's talk about how do we operationalize it? How do we use it? Can we teach it? And we've kind of already said that, but, can we help people to be more hopeful? What can we do?
If you'd asked me 20 years ago, I would have said, we don't know yet. Now we know. You can, it can be modeled, it can be taught, and it can be learned. And we actually use the expression now, hope work. When we're dealing with this client, we need to do more hope work. And it was a client who said, hope work is what I have to do before I can do the work I have to do. And we actually call that hope-focused practice. One of the first things is to attempt to remove the obvious threats of hope, like pain. If a person's in pain, it's harder to be hopeful. Or if they have been the subject of what I would call indignities, establishing that respect, because literally our actions are not neutral. Every communication has a potential to influence hope, and that's our behavior, but it's also our language. And we're sorting out this issue of language. Like if you use the words, when you're starting to see things are improving, what would you want to do? Or if this could happen, would that make a difference for you? And I love to add the word yet. They say, I'm getting nowhere. And I say, let's add the word yet to that sentence. And they smile. So there's a hope language. And you can't use hope language unless you are listening. And you have to listen for those cues. You have to use questions to hear out that. Often just ask them, tell me the one good thing that happened today. And they'll look at you and say, nothing happened. I say, well, I wonder what will happen tomorrow that will feel better. So you have to have your own hope in place. But we also know from the research, and our research is with multiple populations, that anything that is repeated and positive, like we call them hope rituals. I mean, why do we all brush our teeth in the morning? but also little celebrations. Some of these patients that do well are hope mentors, but so are some of our colleagues. In the course, we address things like, what's your metaphor of hope? Like when my late husband had cancer, everybody was in the, it's a war against cancer, and he said, it's not me, even though he was in the military. And he said, that just isn't me. I'm somebody who cooperates. So we chose a completely different metaphor of how to coexist with cancer and still be hopeful. Sometimes, this is one maybe that you can think about, but for yourself or for a client is to develop what we call a hope kit. We did this with kids that were very disadvantaged and pretty tough, high-risk kids. But we ended up having clients and patients and so forth develop a little hope kit, not much bigger than their cosmetic or shaving kit, with things that would remind them of hope, things that would remind them of the meaning that their life had. And it's kind of fun if you do it in a group. And then to remember all the sensory triggers. I remember the first day I ever saw a woman, and I was doing research, and I said to her, you're beating the odds. I said, what, can you tell me about that? And she said, oh, yeah, it was the cinnamon buns. The cinnamon buns? And she said, yeah, the smell of cinnamon buns. I just always want to remember that. And I said, you know how hard that's going to be to get into a professional journal? And we just laughed, but we started paying attention. We started having people take photographs of hope. We had them, if you could have hopeful music here today, what would be playing? That kind of thing. We had a young man who was 28 years old and very, very advanced cancer. When I said, is there a smell or a texture? He said, oh yeah, my grandpa's riding gloves. He used to go riding with his grandpa. So he actually bought a leather glove, oiled it, and he would bring that to chemotherapy. All of those things sound weird, but they trigger an old experience of positiveness. And so there's sensory. There's a reason why we bring people chocolates and flowers.
Yeah.
So I also think we have to be very culturally sensitive.
Mm-hmm. Yeah. It's really interesting you're talking about that. Yeah, sorry. I'm cutting you off. I didn't mean to. I think it's interesting what you said about the small things, right? And the things, because I think there's a tendency, in healthcare especially, to we want to put everything into very medical or technical terms. You mentioned getting cinnamon buns into the academic literature. But for a day-to-day human basis, for people, the things that matter are things like, memories, things that they feel emotionally connected to, things they look forward to, things that are very mundane seeming, because that's what actually matters to people, to regular people in regular life. That's what we care about. You mentioned about this sort of the hope kits, and having those simple little things that are just so powerfully meaningful to somebody.
I recall when I was teaching, I would ask wherever I was teaching to have a client that I could interview. Well, in one situation, there was a truck driver, quadriplegic, difficult, hard punching kind of guy, couldn't move anything. And so when I was interviewing him, I thought, I have no idea where to start with this guy. And I said to him, what would I need to know about you in order to understand your hope? And he said, oh, you need to know about my son. I'm going fishing with my son. And the nursing staff just looked at me. No one knew he had a son. And so his whole hope was in having this connection, and he and his buddy and his son were going fishing. Well, we just need to inquire. I would also I would like to say too that all hope intervention doesn't need to be individual. It can be in group. And my friend Dr. Sharon Moore, who spent a year with us at the foundation, she started a group for seniors. The youngest was 86 and the oldest was 95 or 6. And they met weekly based on a little book called Finding Hope, and she's written a guide to doing this. So there's lots of things at the very senior level. They're still interested in hope, and they want to talk about hope. And when the group was over, they said, we want to keep meeting.
Yeah.
So I know
Absolutely.
we've gone, quickly over so many things, but there are so many ways. If your orientation to your work in life is hope, you will see the opportunities.
Yeah, absolutely. And we've already started talking about our last question. That's why I've switched to it. But yeah, the orientation thing, I think that's one of the biggest pieces of the puzzle, is that we have to ourselves be committed to that kind of perspective, that we're going to approach situations with that idea. And that example you gave of the man who had the son and nobody knew about that, again, we get so wrapped up in like, we've got to, do our assessments, ask the questions we need to ask, we need to figure out the things we need to ask about, that we miss sometimes the bigger picture of a person's life, right? And that's where the hope is going to live, in that person's life, in their day-to-day things, the things that matter to them, the things that remind them of the past or make them, feel hopeful for the future or comfortable in the present, whatever those things are. Those are the things that are going to matter to that person, more so than any kind of technical stuff we want to know.
They have an amazing capacity to coexist with what I would call suffering, whether it's existential or pain or physical, when they have hope. And it just, you just go, wow. And maybe in some ways become mentors of hope.
Yeah, absolutely. And I think one of our key tasks is to be very mindful that we're not destroying people's hope, that we're not, creating an environment where hope goes away for that person.
Peter, I think you've made a really important point in that I only saw one study on what and who is it that dashes hope, and it was healthcare providers, and I went, oh, this is not good.
Yep.
So our language, our behavior, our smile, our surgeons, the everyday person who just says, hope you have a good day. I mean, it can be so small and it makes a difference.
Absolutely. Yeah, the way we address things, the way we talk about things, the attention we give to people. You mentioned listening earlier, like even just listening to somebody, even if we don't really say much or specific about it. I mean,
the idea that listening is just listening might be the most important intervention that we make, and not judging, and not trying to be the coach, not trying to convince them that's not their way. Just listen.
Yeah, and let someone talk through something, and let them share their stuff. And the things that come out when you give someone space to just share, right, is pretty remarkable a lot of the time. At least that's been my experience, is the things that they will bring out that, because again, we talked about assumptions, right? So coming into a clinical situation with somebody, you're going to be carrying assumptions, particularly, if they have a particular diagnosis or if you've, heard things about them already. But just keeping that space there to learn about them, to know who they are, to be that curious listener. The hope doesn't come from us, essentially. It comes from that person. We help bring it out, and they also react to the way that we are, because we're giving off that, like you said, that energy of what we think, what our beliefs are about the situation, or our own story, right? Our own situation when we were in that same spot, if we were, and which sometimes we have been in the same spot, whether there are someone we care about. So.
Just to add a little bit of levity, we had a very fun project for probably the better part of 10 years. It was called Hope Kids. And it was stimulated by one young man who wanted to make a difference with people who were sick. He is now an intensive care physician. But at the time, we had as many as 300 kids visiting shut-ins. And we trained those kids in hope strategies, and we had them go in groups, and it was just amazing. I mean, those kids who are not academics, who are not professionals, could go in and talk to a grumpy grandpa because they were sent into the rooms not who had, easily, lots of visitors. They were sent into people who didn't get any visitors. And these kids would come out and they'd be buddies with these older men or women who had no one. And these kids could just somehow connect because they weren't coming with all kinds of assumptions about outcomes or, what things should be. So that was a wonderful project. So kids can do this as well.
Oh, yeah. Which again, also goes to show you that we should certainly be able to do it as well. It sounds like it's possible for anybody, right? I mean, anyone can learn to do this. Anyone can bring that perspective. And I think even at the sort of basic level of, what's like the first thing you could do for this is about that orientation, is about taking that mindset of hopefulness.
Yeah.
The
fellow who was a major contributor to starting Hope Studies Central, he had very, very advanced lymphoma. And at one point I could see him turning the corner and I said, okay, Jack, what happened? He said this little kid came in, bald-headed, with a wooden toy, pushing an IV, and he said, can you fix my toy? And Jack said at that moment, he thought, if this little kid can do it, I can. And he gave him hope. And I mean, 11 years later, as I said, he died of something else. But you never know where the hope's going to come.
Yeah. Yeah, I think that's the thing that, we want to find the answers. We want to know, like, this is the thing or that's the thing. We won't know until we find it, right, with somebody. Each individual person. It really is their own story, their own journey, in ways that...
Go ahead.
Sorry, go ahead.
Well, I believe there's no context in which hope is inappropriate. There's often the issue of, well, what about false hope? Well,
yep.
In another discussion, we talk about that, but I also say, what about false despair?
Mm-hmm.
That is equally as damaging. And I can think of a person who came to one of the Hope Studies summer courses, and she was a chaplain in an Alzheimer's institution. And you think, wow, that's tough. But she went back and started to do hope-oriented things, and she found out that one of the fellows who would never eat in the dining room, he just stayed in his room, used to have a dog. So she brought her and her dog, and she and her dog and this fellow had lunch together for quite a few times, and then he started going out into the communal dining room. So it's not fast, it's intangible, and it's wonderful.
Absolutely. And it does require us to be creative sometimes and use our imagination, right, to understand how a person is.
Yeah. We talk about 7 C's of hope, and community, communication, but creativity is one of them. And that's because it's in the right, it's sort of a right brain activity. That's why we do painting and poetry and music and things that I used to think were kind of fringe. But now I realize they're important.
Absolutely. I know in my own practice when I was still working, to me, those moments where you would find these sort of intangible or unexpected opportunities, with somebody, whether it was through a creative outlet or through some other aspect of their life, seem to be extraordinarily powerful in terms of what you would maybe call progress for somebody.
Yes.
Because it unlocks something in people, right? Yeah.
I think we should remember to put humor in there.
Absolutely.
I remember I was called up to see a fellow who was really being difficult with the staff. And he was really frustrated because the meals were terrible. And I found that often meals were the target of other people, of their anxiety or their anger or whatever. And he'd had a baked potato that came up and it wasn't done. And a nurse walked in, a friend of mine, and I told her that he was really upset about his baked potato. She picked up the potato and spanked it. and said, bad, bad potato. Well, he burst out laughing. And suddenly 2 people were listening to him about this potato and spanked it, and we got him another potato. That small an intervention, he just wasn't difficult after that. And
Absolutely.
you know, you don't read that in textbooks. You just get it from experience and realize that if you tune into somebody, you can get that sense of what is it that would lift their spirits? What is it that would, you know, make them willing to stay here and take tough treatment for however long they need it?
Absolutely, absolutely. And just on that last humor point, I think we're going to move to the questions in a second, but on that humor point, you know, thinking again about that stance. So when we go to talk to somebody about something serious, we you know, just as humans, but also as particularly as professionals, we take on like a professional, like serious kind of stance with things, and that's, you know, obviously being respectful, but also remembering too that, you know, it's a person-to-person interaction. So, you know, there is something to be said for being a little bit more warm and being a little bit more human in that situation. And I do honestly think that a lot of people, their way of coping with those difficult conversations is just to like kind of go into automatic mode and be very serious and like very much in this sort of persona, just because it makes it easier. It cushions the emotional impact of having to have those kinds of conversations or deal with those situations, but it doesn't help the situation, right? Because that warmness, that kindness, or whatever it is in that moment, whether it's humor, you know, can really help to sort of instill that idea that like, yeah, like, yes, this is, you know, a tough situation or it's bad news or whatever it is, but we're, you know, there is still more. There is more than just that. It's not just this bad news. There is more to life. There's more to the situation.
Absolutely. And sometimes if you say, you know, have you ever had a situation that's been as challenging to you as this? If they say no, you're able to lightheartedly say, well, no wonder you don't have any practice at this. And if they say yes, and they can identify skills or behaviors, then you can build on that and say, wow, you're ahead of folks because you had that experience. So
I think we should move into our questions.
You have to use your radar.
Yeah.
I mean,
well, that's it. Yeah, it's like brand new, right? Everything's brand new when you're in those kinds of states because I don't know what to do with this. All right, so let's move into our questions and answers. Right. So I think they're starting to show up in the chat here. I think I just pulled them out of the Q&A. So
yeah, I'll just interject here, Peter. It's Jillian speaking, and just remind people, for those that aren't familiar, how they can ask their questions, and then we'll go from there if that's okay.
Cool. Sounds great. Thank you.
Perfect. Thank you. And thank you to both of you for this conversation. I think it's always nice when you just have sort of this back and forth and exchange and the sharing of experiences. So I really appreciate that. Okay, so yes, if you'd like to ask a question to either Dr. Jevne or Peter, you're more than welcome to do so. I already see some in there that I'm going to get to in a moment, but for those who have never done that before, you can just type your question into the type here section. Actually, scoot this over here so it's a bit larger. There we go. So on your bottom left of your screen in the type here box, and then just click on the arrow and you can ask your question. If you have a specific question for one of the presenters specifically, then please indicate that in your question. Otherwise, I'll just sort of pose it to both of them and give both the opportunity to respond. I also want to note that during the last 5 minutes or so of this question and answer period, I'll be posting some poll questions, and I invite you to take part in those poll questions when they pop up, and that just makes sure that we're on track and helps guide us in future webinars and that sort of thing. So they'll be posted shortly. So with that in mind, I will sort of jump around here, Dr. Jevne and Peter, but I see a couple questions here about the author of the Finding Hope book. Can you, and perhaps Dr. Jevne, I think it was you that referenced it, so are you able to provide the author of that book as if people are interested in looking at it?
Yes. The author of that book is Ronna Jevne.
Perfect.
Yeah. It's on Amazon, and be sure to get the second edition. because it is different. So
Okay.
look for the second edition of it.
Finding Hope.
And Finding Hope, and it is based on our first sort of 10 years of the foundation, where we took what we found in research and tried to turn it into very one-page strategies that people could actually do. So underneath it is a framework of research, but it's very, very much in the vernacular. It's very small, and it's Ronna, Jevne, and Jim Miller, but be sure to get the second edition. And also, if you
I'm just having a peek right now, Dr. Jevne, is the second edition, would that be the 2020 publication date?
Yes.
Okay. I will just post it.
And if you're actually serious about, you're in extended care or something and want to, then email me, and I'll have Sharon Moore email you the guide to doing a group with that book. Okay. Perfect.
I just posted it. Hopefully you can all see it. I just posted the link up there as well, just an Amazon link, but certainly we encourage you to go to local bookstores as well if at all possible. So we'll just leave it at that. But thank you so much. That came out quite a bit, so it's wonderful.
Okay.
I'm going to go to another question that I think is really sort of relevant, particularly this time of year, because it is a difficult time of year for a lot of people. And the question is, how do we offer hope when we ourselves may be feeling hopeless?
Is that directed to one or the other of us?
Either of us.
Okay.
Yeah. Maybe Dr. Jevne, you can start, and then Peter will give you an opportunity to respond as well.
Sure.
My first suggestion was, to the degree possible, do no harm. Don't drag someone else into the hopelessness. The second is, take 2 or 3 months and really address your own hope. There's nothing like just stopping and going, okay. There might be also some things that you can look at on Hope Studies Central website, which I see somebody's asking. Just Google Hope Studies Central, and it will come up. But really look at, what's your own hope story? Is your hopelessness right now related to work, related to home, maybe related to both of them not doing well right now? Like, really stop and do what we call reflective practice. And if it's beneficial to you, talk to a good friend, or actually go and see somebody and say, you know what? My hope is down, not a pint, but a quart, and I don't know where it went. There's lots of contributors to hopelessness. The world actually right now, the context of the whole international world is not hopeful. And so we need to be very intentional about hope. I'll stop there. I'm sure Peter has something to add.
Yeah, I mean, obviously I'll echo that, if you can work with someone else to help you kind of process this and understand it. And I think the other piece of it too is really thinking about this sort of how hope is multidimensional. Because, yeah, there are lots of things in the world, and maybe specifically in your lives, that may be making you feel hopeless. I can appreciate that, absolutely. And I think, too, when we go into, so say we're going to work with someone, and, we want to be hopeful, we want to support them, I think it's really important to think about, what is my priority in this situation, right? I'm here, I'm with somebody. What is it why am I here? What is my purpose here? What is it I'm trying to do? Because as much as, yes, like, that hopelessness can certainly leak into those interactions, and we can start to feel cynical or whatever else we might be feeling in that moment, I think it's really important to remember, what is my actual goal here? What is it I'm trying to accomplish? And while you're doing that work to try and figure out your own state of hopefulness, to echo what the Ronna said, like, to not drag someone else into that, to bring them into that. When you're trying to be different for them, you're trying to do that, and to then find the hope in that, right? Because I think a lot of times I hear this a lot from other professionals, we tend to feel kind of like, yeah, I'm just like, dropping the tiniest little drop in the bucket of everything that's wrong in the world by helping a person. But in the situation of that one person, like, they can be very, very significant, much, much larger impact just for that one person. So, I know at times when I have felt like certain degrees of hopelessness about things, that has been really helpful for me to kind of turn around and say, okay, yes, sure, the world is terrible, lots of bad things happening, the healthcare system's a mess, all this stuff, all true, but also that's not what I'm doing here. Here I'm with another person, and this person needs something from me or wants something from me. And in this moment, I can find the hope in that dimension. It may not be in every dimension of my life and every dimension of existence, but in the dimension of the relationship I have with this person in front of me, there can be hope. And there can be hope for that person, that something can work.
Well, and I'll chime in. We all get tired of institutions going through these mission statements. And you go, oh, yeah, another mission statement. And they're bland, and they're not all that useful, in my view at times. They're kind of motherhood. But I write a mission statement for my own life, and I keep it on the side of my blotter. And it's short, and it's concise, and it's specific, and it helps me prioritize. If something I'm asked to do doesn't fit one of the 3 criteria in my own, if you want to call it hope vision, or on my own mission statement, then I say no. Because if you fill up life with things that aren't on your own horizon, there's not room. And I often think that many of the professionals that I have worked with whose hope is down is because they are amazing problem solvers, but problem solving gets tired, and they need the creative. They need to do photography or music or be in nature or something that replenishes a whole different side of them, but they are so effective at problem solving that part of their life slips away.
Absolutely.
Thank you
End
for
of
that.
my suggestions.
There was also a question about the 7 C's. Can you reference all 7 of those 7 C's, perhaps?
You might find them on Google. I don't know if I can remember. It was part of some lecturing I was doing, and I pulled together, but communication, coping, creativity, community, celebration, that's 5 of them. That's not bad for recall. But I'm not sure if you could see them on Google on one of my lectures or something. I'm not sure. But I was just using the 7 C's in the sense of you say all the 7 C's and here's what you need.
I think I found them here. 7 C's of health and wellness: connection, communication, compassion, community, creativity, caring, and collaboration.
Okay, well, that's an adaptation of them. Okay.
Oh, is it? Okay, I wasn't sure. That's why I didn't post it.
Yeah.
Those are all good things, though. So.
All good things, yes.
Yeah, those are all good things, and all part of hope, for sure.
Perfect.
Yeah. I sometimes think we don't pay enough attention to creativity and celebration. If we make memories, we can call on those memories when things are difficult. And maybe making a memory is just lighting a candle at dinner once in a while. Or maybe it's eating dessert first. Or they don't have to be, in a big neon sign. They can just be something that just changes your life a little or makes you smile.
Absolutely. Yeah, we do. And that's a really interesting, that point, because I think that's a really big sort of like social cultural norm that we try to like swing for the fences with stuff, like, oh, we have to have the thing that fixes everything, versus like finding those small victories, those small little moments that help us kind of get through what we're trying to do, so that we can have some enjoyment or enjoy some things or find those special little moments. Yeah, I really think that's a huge part of it. And It's actually, and as a clinical person, it's actually not that hard to help people find those.
Yeah.
You know, compared to sort of the bigger picture stuff.
I'm cautious of time. I know we're at 1, but I'm going to, if I can spare you or ask you to spare a few more minutes with us, because this question has come up twice, so I want to pose it to you. When working with older adults, in your experience, what do you feel is the best assessment tool when working with clients? What should always be part of our practice, given that there are so many tools? Any suggestions on a particular assessment tool or scale or form that you would use in practice?
Okay. Peter, maybe I can address that one?
Yeah, you should take that one.
Yeah, okay. One is, I think you should look at the work, if you are in a counseling role. Now that, or at least part of your work is in counseling, you might want to look at the assessment instrument that Dr. Denise Larson, who's now head of Hope Studies Central, they have been looking at assessing the process by which hope develops in a counseling relationship or in a professional relationship. So that's different. But also anything that's developed by Dr. Kay Herth, H-E-R-T-H. She specifically has looked at assessments of hope within the nursing, particularly within the nursing context of assessing hope with the elderly. So I would trust anything that Kay Herth has done. I won't go on and on, but those are the two that I think of. If you're in someplace where you're working at the process, you would want to look at Dr. Denise Larson's work. But if you're looking at specifically the elderly and wondering, you know, what is their hope level, look at Kay Herth. It's K-A-Y-E, Herth, H-E-R-T-H, that you'd want to look at. If you're looking at students and achievement, that's different. There's a whole body of work by Rick Snyder, but this isn't our population today.
Well, thank you so much. I am going to have to leave it there, and I know it's 1:02 Eastern, so I do want to just express my gratitude to, of course, our two presenters today, Dr. Ronna Jevne and Peter Snow. Such a pleasure to have you both with us and to have you share your insight and your perspective and expertise. Just looking already at some of the comments, I know I'm not alone in my gratitude and appreciation for this topic and for your time today. So thank you both very, very much. And of course, thank you to our participants as well. Always lovely to have such great questions and engagement. Makes for a wonderful webinar when we have that sort of interaction. So that's great. Well, so I will leave it at that. I'll leave the slides or the webinar up for a few more minutes just to allow for more people to answer the questions if need be. So maybe I'll close in 5 minutes from now. But I will close to all of you on the audio. Say thank you very much. Peter or Dr. Jevne, any last words before we head out today?
Please feel free to give my rjevne@ualberta.ca email out, and I'll answer questions or give directions to resources if I can.
Okay, and I'll post that in the chat pod as well for people to have a peek at.
And thanks, Peter. You've been great to work with.
Yeah, thank you too, Ronna. It's been great talking with you and working through this process to do this. I'll just give one quick pitch for CCSMH. So if you're not aware of us, we're an organization doing work in seniors' mental health. We've got a ton of great resources in anxiety, depression, dementia, substance abuse. So go to our website, ccsmh.ca, and we're hopefully doing more work in this hope area in the near future. Thanks again, brainXchange.
Well, I will reinforce Peter's view of that. I went looking for organizations that were involved in seniors' mental health, and this is the best one I found.
Well, there you go. That's a plug, if nothing else.
I'll take it.
Wonderful. Well, thank you so much to you both. Thank you, everyone, for joining us today. If we don't speak to you before then, happy holidays to everyone. All the best and a healthy 2024 to you all. And enjoy the rest of your day, everyone. Take care. Thanks so much. Bye-bye.